The topic of access and affordability of therapies like the CAR T-cell therapies is quite a hot topic, especially for the patients. Luckily, we have these therapies here to change the patient course, the trajectory of the diseases. But it is also true that from the logistics point of view, from the pricing point of view, is quite demanding for the systems, is not always delivered the best way. Geographically talking. For instance, I remember when the CAR T therapies were first approved and they come to the market, they were possible only in a few countries. They are still possible only in a few countries. But I'm afraid some countries have like in a very central places, and you not always can bring the patient to the place, especially patients that are critically ill may not have the support that they need, and this adds much more costs also that are not running under the basket of services of the healthcare systems, neither the provider of the treatment, the commercial provider of the treatment, but needs to be out of pocket from the patients. That's one example, but also affordability. We cannot keep bringing medicines that are coming with higher and higher and higher prices. I'm afraid the resources are limited, the financial resources are limited. And I'm not telling that these therapies are not welcome. We are all keen to adopt them. But we need to understand also that the return is true that it's very expensive to bring those therapies in, but it's also about the return. How long you need to bring that return. And I always stress that many of these developments started in the academia world. So if I start like representing as cost expressed in monetary concepts, I mean, how much it worth the life of a patient that voluntarily joins a clinical trial? That piece is not in the equation. When we are pricing the medicines, we are taking only what was invested from the research perspective. I'm not telling that they should come to a higher price either, but we need to find a balance, because what's the point of bringing therapies that at the end cannot be adopted? We need also from the other side, from the healthcare systems management, we need to understand also how the novel therapies can save costs long term. So for instance, how many resources you won't be consumed because you are fixing a problem earlier on the patient journey. For instance, if you are providing a curative approach versus a therapy that was before in the market that was just extending life for a number of years, but it's not promising a curative approach, that patient will continue consuming resources. But I'm afraid those costs are not well represented, are not well collected into the systems. So I think that one of the areas where we need to put the focus when we talk about access, accessibility, there are several barriers for access and there are several dimensions of access. One thing is the access to the therapy as the treatment, but also access to information, access to supportive care, access to the centers, access to the hospital, access to the best care possible, and not necessarily think that the best treatment, the last treatment that came into the market is the best option for every patient. Patient preferences need to be there when we are taking the decisions. So when that concept of shared decision making that I personally understand as the need to incorporate in that dialogue what the patient expects from the treatment, what are their personal expectations, what are their personal preferences, what are their goals, and they may not be the same for different patients, and they are not static. What could be my preference today may look completely different 3 months after, depending also on my quality of life and my personal environment. So, just to recap, access to information, first of all. Patients need to be informed about the therapies that are available. Secondly, we need to report better what these therapies can do for the patients, for potentially curing or treating better the diseases, and for that we need to collect data. And I want to thank the EBMT for the good work they do by collecting data in a voluntary basis and to try to bring that knowledge and to translate that knowledge into better clinical practice. However, for the CAR-T specific setting, I want to stress that the data is collected from the moment of the leukapheresis, from the moment of the infusion, sorry. So the patients need to have the leukapheresis first. That's one access first to that pre-treatment, let's say. And then you have the manufacturing. That's another access issue because you need to have slots. For instance, in the myeloma space, there are not many slots available for manufacturing the therapies. Then the product comes back with the modified cells and needs to be infused to the patient. That's the moment when you start collecting data, when that infusion was achieved. What happened with the patients that got the leukapheresis done but never achieved the infusion with the modified cells? We are losing understanding what are the issues there. And I'm afraid we are losing patients in that setting. And this is a call to action to EBMT and to national registries to improve that. I know it's not easy. I know that collecting data is hard, it's expensive, requires resources behind. But we need better commitment from the governments, even from the European Medicines Agency, to make that possible. It's the only way to move forward and to really overcome the different barriers we have along the trajectory.